with history of fever and fatigue for the last 4 weeks prior to presentation. She was found to have pancytopenia and she was referred for further workup. Her past medical history and past surgical history was no past history of malignancies or no any hematological conditions. She has a history of chronic gastritis, osteoarthritis, and hypertension. When we reviewed her family history, it was negative for any hematological conditions. And in physical examination, she was pale, no lymphadenopathy, no organomegaly, no splenomegaly, no hepatomegaly, and she had a painful external hemorrhoid. Laboratory investigation showed that CBC hemoglobin 89 gram per liter, white blood cells 2.3, platelet count 42, absolute neutrophil count was 0.16. So she was pancytopenic on presentation. The coagulation profile, INR, BT, BTT, all were normal, and hepatic profile was normal also. The renal profile was normal, LDH was mildly elevated, 221, uric acid 160, which was normal, and peripheral blood morphology confirmed the pancytopenia with circulating blast more than 50%. Flow cytometry showed CD13 positive, CD117, MPO positive, HLA-DR, CD34, and then CD33, CD38, and CD45. So all myeloid marker were found. And the flow cytometry was negative for lymphoid marker, CD3, CD20, CD19, CD10, all of them were negative. And this is the bone marrow result. So bone marrow aspiration, there was reported as several hypercellular bone marrow fragments and blood cells estimated to be 100%. These cells showed the high NC ratio with prominent nuclei. The trilineage hematopoiesis was markedly reduced, and the bone marrow biopsy was showing cellularity of 100%. It was completely effaced bone marrow and replaced by blast cells. Trilineage hematopoiesis was markedly reduced. Cytogenetics, the karyotype was 45XX with monosomy 7, and the MNDS FISH panel was negative. Unfortunately, I couldn't find the full molecular at the initial presentation, but here is the from the ASH bucket, what's the recommended molecular in this case. So if we follow this, she should have FLT3 at the initial presentation, and IDH1, IDH2, all of these should be reported. But it was like negative in the report. So based on this, what's the diagnosis as per WHO classification? Is it like ML with recurrent genetic abnormalities, or ML with myelodysplasia-related changes, or ML none otherwise specified? So we could argue that this patient could be considered as ML with myelodysplasia-related changes because she has monosomy 7, which is known to be associated with MDS. But on the other hand, there was no clear MDS changes by the morphology. And this is a brief about ML with MDS-related features. Any one of these we can consider as ML with MDS-related changes, either ML that evolved from previously documented MDS, which is not in this case, or if ML that demonstrate MDS-related cytogenetic abnormalities such as monosomy 5, deletion 5q, monosomy 7, or deletion 7q, isochromosome 17q, one of these. The other option, if there is a ML with morphologically unidentified multilineage dysplasia, defined as dysplasia present in more than 50% in 2 or more hematopoietic lineage. So we don't have the first one and we don't have the third one, but the second one is like monosomy 7, it could be associated with MDS. On further assessment of the patient before starting the treatment, the performance status was Karnofsky score 80, and ECOG is 1. Echocardiograph shows normal ejection fraction. Comorbidity assessment, she has only hypertension, as I said, normal renal function profile, normal liver function profile. HLA typing was full match sister. So what's the risk stratification of acute myeloid leukemia in this case? Is it favorable risk or intermediate risk or poor risk? Because she has monosomy 7, we would go with the poor risk. And as we all know, this is this risk stratification: favorable risk, intermediate risk, and poor risk. And you can see monosomy 7 is one of the poor risk features. So which treatment option we have to go? We have multiple options now, and it's not anymore 7+3. We have now 7+3. You can also reduce the dose to 5+2, CBX351, or azacitidine, gemtuzumab, or transfusion or supportive care. The standard care, it used to be like 7+3, and we went with 7+3 in this case. The induction, patient received 7+3 idarubicin based, and she received antibiotic treatment for perianal and pelvic infection. And the patient, as I said on the presentation, she had thrombosed hemorrhoid, and she had excision of thrombosed hemorrhoid under GA. Complication of the treatment of chemotherapy, she developed bradycardia, but she was like asymptomatic. It was presumed to be Cytarabine related. It's reported in multiple reports in the literature that Cytarabine can cause bradycardia. But for some reason, we have multiple cases in our center. We noticed that bradycardia can be associated with high dose Cytarabine. Day 14 counts was white blood cell, hemoglobin 75 and white blood cells 0.59, platelet 15. The day 14 bone marrow was showing hypocellular marrow with blast 12 to 13%. She was not in CR in the day 14 assessment. This is a brief about Cytarabine-induced bradycardia. So this patient has here bradycardia, as you see in the chart, with the induction, and then she received Cytarabine with the salvage. When she relapsed later on, she has bradycardia. So there are multiple case reports about Cytarabine-induced bradycardia, and now we are collecting also the cases in our center of bradycardia associated with Cytarabine, and we will report them later. So next step, like we have day 14, still there is 12, 13% blast. Which way we have to go? Do we do like reinduction or salvage, or we continue supportive care and rebuild bone marrow after count recovery? What we did actually, we waited for some time, and on day 22, unfortunately, she recovered with a blast. She recovered her count with a blast. White blood cells was 1.2, hemoglobin 78, and platelet 16. So blast was 6% in peripheral blood. And decision was taken to reinduction or salvage by MEC chemotherapy, methoxyntron, etoposide, and Cytarabine. Day 14 counts after MEC was showing hemoglobin 75, white blood cell 0.1, and platelet 9. Day 14 bone marrow after MEC was showing hypocellular marrow cellularity 10%. So still, she was not in remission. But we waited some time, and we repeated the bone marrow at day 30 after MEC. It was showing cellularity 20% and no abnormal cells seen. So she was in CR1 after MEC. So now, what's next step? She is in CR1. Do we go for consolidation with 3 to 4 cycles of HiDAC, or we do reduced intensity allogenic stem cell transplantation, or we go full myeloablative allogenic stem cell transplantation? So we chose to go with REC, reduced intensity, and after achieving CR1, the patient started workup for allogenic stem cell transplant, and meanwhile she received 2 cycles of high-dose RSC, 2,000 milligram per meter square, as consolidation while she was doing the workup of transplant. She tolerated chemotherapy very well, but she developed backline thrombosis treated by low molecular weight heparin. So now, if she is going for transplant, which conditioning we have to go with? Cytarabine or busulfan 16 doses with cyclophosphamide, busulfan 8 doses cyclophosphamide, or flu-bu 8 or flu-bu 8 doses with ATG, or flu-bu 12 doses with ATG. Because we decided to go for reduced intensity, we chose the fludarabine busulfan 8 doses with ATG, which is reduced toxicity and less toxicity than bu-cy, the standard treatment for patients who are more fit, because the patient is almost 6 years old and she has hypertension and so on. The transplant details: donor was sister, full match for class 1 and 2, HLA 10 out of 10, conditioning reduced intensity busulfan, fludarabine, and antithymocyte globulin, rapid ATG. Day 0, 16 May 2016, CD34 was 4.3 millions, and neutrophil engraftment was in day 17. Platelet nadir, 47,000, so she did not go very low thrombocytopenia because of reduced intensity conditioning. The hospital course was complicated by CMV activation, treated by foscarnet, then the patient was discharged on valganciclovir. She had also febrile neutropenia, all culture were negative, and there was no focus in CT scans. The patient was discharged and she continued to follow up in the outpatient clinic. It was an uneventful course. 3 years after transplant, the patient, let's start with the chimerism at day 90. It was 100% donor cells for myeloid and T lymphocyte, and she maintained 100% chimerism throughout the 3 years of follow-up. But unfortunately, after 3 years of the transplant, in June 2019, she presented with multiple skin bruises and fatigue. Chimerism at that time showed myeloid 72%, so she started to lose the chimerism, and lymphoid was 100%. She was found to have white blood cell 6.6, hemoglobin 10, and platelet 9. Bone marrow showed relapse with 50% blasts, and at that time she had acceptable performance status. So this is the result of the bone marrow flow cytometry, also myeloid marker CD13, CD34, CD117, CD33, HLA-DR, CD38, and CD11. And it was negative for CD3, CD20, CD19, CD10. Cytogenetic test showed karyotype 46XX, but only one cell was analyzed. They couldn't analyze 20 cells, which is the standard in this case. But the one cell that they analyzed, which is not sufficient, they found it's 46XX. And the fish for monosomy 7, it was positive actually. So she relapsed also with monosomy 7. And this time we found MLL rearrangement. And the molecular test was FLT3 negative, MPM1 negative, CBBA positive, but it's only single, it's not the biallelic. And DNMT3 was positive, IDH1 negative, IDH2 positive, and c-KIT was negative. So we have some molecular tests which are positive, and here also we have the MLL rearrangement as well. So what's the next step of management? Do we go with salvage chemotherapy, like curative intention, or low intensity azacitidine, or supportive care only? We decided to go with salvage chemotherapy because the performance status was good of the patient, and we went for salvage by CLAG, cladribine, cytarabine, and GCSF. The treatment was complicated by middle ear infections, febrile neutropenia, gram-negative bacteremia, and day 21 of CLAG chemotherapy, she recovered her count with blast, unfortunately. So white blood cell 2.6, hemoglobin 75, and the platelet 20, with the blast seen in the blood film. Bone marrow confirmed blast 40 to 50%. The patient performance status deteriorated because of chemotherapy and long duration of admission and recurrent infection. ECOG was 3. Next step, second salvage or low intensity chemotherapy or only supportive care. We decided to go for low intensity regimen because the performance status of the patient was not that good. She was in the hospital for a long time, recurrent infection and so on. But which low intensity regimen we have to go with? Azacitidine or low dose cytarabine, venetoclax, azacitidine or venetoclax plus low dose cytarabine, gemtuzumab, enacidinib. So she actually started salvage chemotherapy by low intensity chemotherapy, venetoclax, azacitidine, 75 milligram per meter square with venetoclax ramp up with target dose of 400 milligram once daily. The patient received first cycle, which was complicated by hepatotoxicity, cholestasis, hyperbilirubinemia. It was presumed to be due posaconazole, the antifungal treatment, which was like prophylactic she was taking, or maybe it's related to venetoclax. But at the same time, she had signs of infection, febrile neutropenia, and multiple microabscesses was seen in the CT chest with features of cirrhosis. Because she was febrile, she was treated by antibacterial, antifungal, and the fever was subsided later on. Bone marrow biopsy after cycle 1 of venetoclax azacitidine showed bone marrow in normocellular and CR2 achieved. The patient continued consolidation by azacitidine venetoclax. She is now receiving cycle number 3. Her performance status is ECOG 3, and liver enzymes improved after stopping posaconazole and reducing the intensity of venetoclax. So here we have multiple options. Either we go by second RIC transplant, but there are multiple issues with that, like performance status, toxicity, and what's the outcome of second transplant, and problems with the donor, because the donor which we have before, the donor, the matched donor is not available now, so we will go for haplo if she is going for second transplant. The other option is to continue chemo maintenance with venetoclax, but here we have issues with the dose, toxicity, the liver hepatotoxicity, and so on. And the third thing we have to consider for the management of this patient is the quality of life. She is staying in the hospital now almost 5-6 months. So what are the patient preferences, and all this we have to take into consideration before deciding the next step of treatment. And thank you. And if you have any question, okay. Thank you.
You're referring to the data I showed on maintenance, which was a HOVON study in patients with AML in remission after induction chemotherapy who were randomized to subcutaneous azacitidine or not. We showed an improvement in disease-free survival, but no improvement in overall survival. And the likely explanation for that, there are two, I think. The likely explanation is that in that study, quite a lot of patients who relapsed were salvaged with an allogeneic transplant. So that blunted the survival benefit of that study. But the alternative explanation, I think, is that oral azacitidine may be a more effective agent in the maintenance setting than subcutaneous azacitidine. The pharmacokinetics are different with oral azacitidine, the compliance is better, and the pattern of methylation. So I think we need to actually think about this agent that is coming and developing so quickly, CC486, as a different drug from sub-Q-AZA. I think it has different biological activities, and I think the data has to be firmly on the side that, for whatever reason, subcutaneous azacitidine doesn't do it, it doesn't work, but oral azacitidine does. It may simply, however, have been trial designed, but as you will know, actually giving maintenance to people with ALL is really quite challenging, actually. In the setting of AML and people who've had a lot of treatment as well, having to come up to hospital, the idea of giving people a tablet is so much better than repeated injections with sub-Q. But it's a very good question as to why there was that discrepancy.
Prof. Grad, I have a question. Very interesting observation regarding the cyclosporin levels and relapse. So are you targeting a lower level at the moment?
So this is, I think it's an important point. The question was, given the fact that there are two sets of data now that show that the intensity of, at least two sets, the intensity of post-transplant immunosuppression with cyclosporin is a determinant of disease relapses. We most certainly are. So my sense, I'm sure I'm the same as you, is that I think a key part of actually getting good transplant outcomes is doing simple things well. So I would suggest, and I always do to our registrars, that is around looking at patient weight every day, looking at the drug chart every day, managing lower gut GVHD or diagnosing it and managing it promptly. So any diarrhea post an allo, bring them in if it's significant 3 or 4 times a day or more. Investigate, but sometimes you have to start high-dose methylprednisolone before you get a diagnosis. These simple things. And one of the key things is looking at cyclosporin levels. We measure them 3 times a week, and we shoot for the mean above and below which there was a difference in that study was 170. So we, in patients with a high risk of GVHD, so we do quite a lot of cords still in the UK, we would go for higher dose. Mismatch MUDs, we go for a higher dose, around 200 to 250. Aplastics, we go for a higher dose. But in AMLs with a high risk of relapse, we would not go above 170, and we probably run them a bit lower. And so the critical thing at the weekend when you come in and do your Saturday ward round is to look at Friday's cyclosporin and make sure it's adjusted. And people don't adjust it as they should. So it's probably one of the most important things we can do to reduce relapse. So I totally agree.
One more question. For post-transplant maintenance, the people who are on the CC486 trial, they get that. FLT3 inhibitor positive ones, I presume you are giving FLT3 inhibitors as maintenance. Who do you give the azacitidine to? Or
okay, right. So let's be quite clear. There is no randomized data yet to show that post-transplant maintenance with anything is standard of care. The sorafenib data is retrospective. If you want to be critical, it is potentially highly biased. There's a lot of selection. So it's easy in the UK because we can't get sorafenib, all right? But I don't think it's the case that there is a clear indication that you should definitely be giving sorafenib post-transplant with FLT3 positive AML. I think if you don't give it, I don't think there's any reason to say that's bad practice. Now, you can make a case that, you know, you'd like to consider administering it, and if you can do that safely, then, well, you may not be doing any harm. But I think it's really important to say there is no randomized data supporting giving sorafenib post-transplant. All the data that's published is retrospective, and there's huge potential bias. Point number one. Point number two is we will be getting the results of 1506, and that, I think, will inform us about whether we should be giving gilteritinib post-transplant or not. There is no randomized data with sub-Q AZA. It is not standard of care. It may have significant toxicity. It is possible that it is not a benefit. So I really think it's important that it is not viewed as standard of care. We need to generate randomized data, and the Amadeus trial will be a way of doing that. Do remember that azacitidine is also quite immunosuppressive. You could argue that it's abrogating a graft versus tumor effect. So I think, you know, if you've got a high-risk AML patient going into transplant, there are much more simple, obvious things to do. One would be if you have a patient with high-risk disease who's MRD positive, try and give a myeloablative allograft. We use Flu-Bu-4 up to the age of 55 with no comment. Point number one. Point number two, think about the cyclosporine. Point number three, think about a rapid cyclosporin taper.
I have a question, Prof, about the, I don't know if you have any experience of using venetoclax post-allogeneic transplant relapse. If you have any cases or...
yeah, so I mean, this was a fantastic case, thank you, beautifully discussed. And you've done amazingly well to get this patient, firstly, to transplant, and then to demonstrate that she has a relapse of original disease, not donor leukemia. That was an important part of your analysis, wasn't it? And now to get her into second CR. So I'm really fascinated by this big unmet need about what do we do in terms of managing relapsed AML post-allograft. We published a big EBMT series showing azacitidine can be effective in about 20% of patients in terms of giving UCR. If you relapse late, you do better with AZA. We had a paper in JCO about 6 months ago where we showed you can safely add lenalidomide to azacitidine, and you have a much higher CR rate. It's a small study, but you have a much higher CR rate. So that's worth considering. You don't have an increased risk of GVHD, apparently. And the third thing, of course, is using venetoclax. Now, there is some anecdotal data. I haven't used it, and I think it's perfectly reasonable. But I would suggest that almost in anybody post-transplant now, your considerations are AZA versus AZA-len versus AZA-venetoclax. And I think if you can get venetoclax, it's a pretty sensible thing to do. The real question for you is, what are you going to do now? So I certainly wouldn't do a second transplant. All right, partly because you've got a donor issue, but I think it sounds pretty tough for this poor lady who's been so, although actually if there were a younger patient, there is some long-term survival data, isn't there, with a second transplant. The other thing that came to mind is if you had any DLI stored, do you?
We don't have it locally, but we don't have DLI service yet in our center.
Because you remember the EBMT study by Christoph Schmidt, who looked at patients who had relapse after allo, who got into second CR with whatever salvage. The outcome was about 25% long-term survival with BMT, but it was just as good with DLI. So I think if you're worried about the intensity of a second transplant, if you had DLI, that's worth thinking about.
Speaking about DLI, maybe I missed that part. Do you practice giving preemptive DLI based on MRD positivity post-allograft, or
do we what?
For AML patients?
Yeah.
Do you monitor them, like especially high-risk AML patients? Do you monitor their MRD post-allograft and give preemptive DLIs post?
Yeah, great question.
Rather than waiting for a florid relapse.
So there's two parts of that question, I think. The first is, what is your strategy for MRD monitoring post-transplant, right? So if patients have a stable molecular marker going into transplant, principally NPM1, but MLL, and there's a couple of others, we will measure by MRD transcript numbers 3 monthly until 2 years post-transplant. And if they have emerging molecular MRD, they don't have significant GVHD, we will give them DLI. So that's our strategy if you've got a molecular marker. We otherwise don't do flow MRD routinely. We just do a day 90 marrow. So I think it is sensible to be monitoring MRD where you have a molecular marker and intervening with DLI. And I think your second question is, what do you do about DLI post-transplant? This is a really challenging issue. If that patient had mixed T-cell chimerism at day 100, would you have given her DLI? High risk AML, big risk of relapse, mixed T-cell chimerism, bidirectional tolerance setting up for a relapse, retrospective data suggesting people... Well, actually, we don't know. And there's toxicity, significant toxicity from DLIs, and there's about 8% death, and there's about 30% significant GVHD. So Victoria Potter, through our impact network, has just recruited, closed out, the only randomized trial of DLI for mixed T-cell chimerism after an allograft for AML. We'll have to see what it shows. I think at the moment we underdeploy the use of DLI, and I think if you had a high-risk patient, certainly if they had mixed T-cell chimerism, I would give DLI on the basis of what we know if they haven't a history of GVHD. And if I was going to do things ad hoc and make it up, I think there's quite a good case for considering using DLI, but we don't have randomized data.
One question for, if you have a young patient and he had, like this case, poor cytogenetic induction, would you give 7+3 at this time? Or
it's a really good question. And you know, I congratulate you on the management of that patient. Very complicated. And also I congratulate you on the history. It was really beautifully presented. So we had a big paper in Hematologica about 2 years ago, first author Ferguson. We looked at about 9,000 patients treated on the NCRI data set in terms of diagnosing primary refractory AML, okay? So there are a couple of points that are relevant to this case. The first is we confirm what Jacob Rowe showed, which is if you don't go into morphological CR after one course, you're clearly in a high-risk group. The second thing we showed was that if you are fit and you are not in CR after 2 courses of induction, your only curative therapy is an allograft. So actually, if they're fit and they have primary refractory AML and it's not very proliferative, I think a transplant is reasonable, particularly in younger people. And then your question is a really great question, is if you're not in CR after 1 course, do you give another 3+7 or something else? And actually, there isn't any randomized data. There's some retrospective data, but we would give FLAG-IDA. I don't know that, you gave MEC, I think, didn't you? I don't think there's any data to say that MEC is not as good as FLAG-IDA, but what we would certainly do would be intensify the induction. We would not give another 3+7.
Any more question?
I
Yes,
have 2 questions. So any result of the AML, I think 17 on FLAG-IDA as a standard induction in AML? And my second question is, what's your routine clinical practice in outside clinical trials in patients who are FLT3 positive AML post-transplant?
The first question is FLAG-IDA. Well, we need more randomized data, and that's being currently, it's not at the moment standard of care, I don't think, all right? partly because FLAG-IDA seemed to be benefit in people with adverse risk karyotype, and we've got a drug now, CPX351. So we would be taking patients in the group where there was a FLAG-IDA benefit into receive CPX351. I think FLAG-IDA is very interesting as an induction question. We need more data. It's being analyzed at the moment. So it's either in our hands, DA or CPX, okay? I think there's I mentioned it, it's important, if you can, to wait for cytogenetics in newly diagnosed AML, particularly if they've got relatively indolent disease. Because if you've got cytogenetics that push you towards CPX, the patient should get CPX. And then your second question was post-transplant?
Yes, FLT3 positive AML, routine clinical practice outside clinical trials.
Yeah, okay, I think I touched on this. So you will get different answers, won't you, from different people, and I'm a purist. So I believe that our practice should be informed by prospective randomized data. It's clear there is no prospective randomized data showing any FLT3 inhibitor post-transplant is of any benefit. It's easy in the UK because you can't access these drugs, okay? So I'm not in some sort of crisis because I can't do it anyway. Maybe you can. Maybe you could get sorafenib here, can you? So would I give sorafenib? I think that what I would clearly do is I would put patients onto the 1506 trial. We had an editorial by Mark Liebes and others in the JCO about 6 months ago, which made the really clear point is that we don't know, you have to generate the data. But if the 1506 trial is not open, as you're saying, I don't think it's an unreasonable thing to give sorafenib. I don't think it's evidence-based. I think those historical data potentially are flawed, but if there's no toxicity, I think it's not an unreasonable thing to do. You will speak to other transplanters who will say it's standard of care. And I would say to them, show me the prospective randomized data. We do not go around changing management of CLL or AML or ALL using retrospective historical controls. You have the same rigor in transplant, in my judgment. Hello.
Thank you very much.
Do you need a microphone?
Because there is a question? Okay, one question.
Hi, thanks. I admit that there is going to be a lot of bias in the retrospective data for sorafenib, because we had one of the series of the retrospective sorafenib maintenance story. But there is the Regimen study, which I might touch on, but that was prospective, randomized, double-blind, and there was a
small study, not powered, no MRD.
Right.
Interesting.
Okay.
We need a proper randomized study. If I really feel stressed. I think if you've got sorafenib and you can give it and there's no toxicity, I can't see any reason why not. But I really think as a transplant community, we've got to get a grip and generate proper randomized data that we're confident of. The Regimen study, I applaud them for doing it. It's a very small study. It recruited over a number of years. It's only 90 patients. If you were thinking about how you would be changing care in all the other diseases we treat, you'd really want better data. You really would. And I think we have been, I don't know, for whatever reason, in transplant, but I think we have got used to making decisions based on very poor evidence, on our gut. And that's not how we as hemato-oncologists function. It's not how we should function. We should be much more rigorous, and we should do much more to enter patients into trials. If I was a patient, I'd want to see the good data. If somebody came up to me and gave me CPX351 on the basis of a retrospective study with massive fallout and all the historical bias, I would be less than impressed.
Okay, thank you, Professor